Hi, I'm Heather, and welcome to today's segment of Health Mantra, where we will be delving into a topic that affects millions worldwide: gastroesophageal reflux disease, better known as GERD. Today, we are joined by two esteemed experts in the field. We have Dr. Jagannath Kulkarni, a consultant laparoscopic and bariatric surgeon, and Dr. Rohan Badave, a consultant gastroenterologist and hepatologist, both from Manipal Hospitals, Goa. Together, they bring a wealth of knowledge and experience in navigating the complexities of GERD, shedding light on its causes, the treatments, and the impact it can have on an individual's life. Thank you both, Doctor, for taking the time out for joining us here today.
Yeah, thank you.
So let's start with a very simple question. Let's try and understand, what is GERD?
Gastroesophageal reflux disease is nothing but it is a disease entity where because of the reflux of stomach contents back into the esophagus or food pipe leads to the troublesome symptoms. The symptoms are basically like heartburn, where patients feel the retrosternal burning. They will have sometimes regurgitation, like the food whatever they had in the prior dinner or lunch, it's same taste or same food is coming back into their mouth. Some other atypical symptoms where they get recurrent dry cough, they feel something is getting stuck here, that is called as globus pharyngeus. There are extra esophageal symptom where there is a change in the voice. Some patients who are suffering with asthma, there happens the exacerbation of asthma. So these are the few symptoms they deal with.
Is it very common in nowadays?
I would say it is definitely very common. The reason is today's lifestyle is such that many people they end up having a long duration at work, and the work is quite stressful for them, and they don't sleep well on time. That also can add to the stress. So when their working hours are quite long and stress adding to their life, this ultimately leads to the same thing, that is reflux of either the acid from the stomach or the food contents in the stomach, or both of them coming back into the food pipe, which is not supposed to happen. So this entity wherein the acid and the food, they come back into the food pipe because of the failure of the valve mechanism that we have. The food pipe starts here, goes till the upper part of the tummy, and then you have the stomach. So we are supposed to have a one-way track wherein the food from the food pipe gets into the stomach, and that's it. It shouldn't come back. But various factors which prevent this mechanism, and they lead to a two-way track where the food goes down. Of course, it has to go down, and it will come up as well. So depending on the severity of the disease, people have different symptoms. So they can range from, as Dr. Rohan was saying, burning sensation that they will have, or later on there are some atypical symptoms also which will be presented. Yes, it is definitely a symptom or the disease which is related to the lifestyle of that particular person, including the weight of the patient. That has a major contribution in the flare-up of the disease.
So would we say acid reflux? Would it also be known as acid reflux? Is it the same thing?
Yeah, it is the same thing. So in general layman's language, they say it as acid reflux. So if you ask me how common it is, almost 25% of the adult individuals, 20 to 25.
And this is to do with bad lifestyle.
Yeah, in India they are affected somehow, few days or few weeks, they are suffering with these type of symptoms.
What are the other risk factors involved?
Oh, there are multiple risk factors, or we can call them as causes. The main thing is, they can fall under the whole umbrella of lifestyle problems. See, if somebody is habituated to smoking, somebody is used to alcohol, lack of sleep, or odd food timings, they end up eating at whatever time they want to, not following a particular timing for food, not sleeping well. These are some of the common things which we see. Apart from these known things, there are other things as well. Probably I would say they fall into, not at all related to patient factors, but they cannot be prevented also. So such as if the patient has some medicines, the patient has to take medicines for better health of other such conditions. Medicines can lead to gastritis. And then there are some surgical causes, which I would say, wherein the patient has nothing to do with that, there are some bigger openings in the diaphragm muscle, which is the muscle that separates the chest from the abdomen. That's called a hernia, or a hiatus hernia is what we call. That's not under patient's control. If patient has those conditions, even that can lead to reflux problems.
Okay, doctor, you said something about alcohol. What about things like spicy food and oily food and
Yes, definitely. So, main the risk factors, as Dr. Jagannath has mentioned, few more to add up is obesity. The person who is having obesity, they usually suffer with these reflux symptoms. Alcohol, yes, definitely. Alcohol is irritant to the stomach, so it leads to the more acid production in the stomach and then the reflux. Other risk factors are the carbonated beverages, then coffee and chocolate. So this coffee contains caffeine that relaxes the lower esophageal sphincter or the wall, which Dr. Jagannath was talking about. Similarly, in the chocolate there is a cocoa powder, and it has been shown that this cocoa powder leads to the relaxation of sphincter, or it becomes more lax. And carbonated beverages, we all know it has that carbonated stuff. That's why we get a lot of burps after eating that. When the gas comes up, similar time some acid comes up into our food pipe, and that leads to exacerbation of this reflux symptoms.
How would you diagnose that a patient is suffering from GERD?
Yes, I mean the basic mechanism in this reflux disease is that either it is increase in the volume inside the stomach, which is basically beyond the pressure the stomach can handle, and then it will open up on the upper side, that is towards the food pipe. So volume increase inside the stomach, or something that is pressurizing the stomach from outside. It is definitely inside the abdomen, but outside our stomach wall.
Yes.
So if that pressurizes, for example, the best example is
hernia.
obesity.
Okay.
Obesity is something wherein the abdominal pressure is so high that that pressure, it presses the stomach, and leading to whatever the food that is there, it can reflux into our food pipe. Another physiological condition, that is pregnancy. So many women, they experience a lot of dyspeptic symptoms. That's what we call them, that they have dyspepsia, that is regurgitation and heartburn related symptoms. So that is one of the things which, I mean, these are some things which are there. So we just need to recognize these things.
So for diagnosis, basically there are various tests are available, but usually, as Dr. Jagannath said, these are the classical symptoms. One is a heartburn and second is a regurgitation. Regurgitation means the food coming back into your mouth. So if these two classical symptoms are present.
How often? Like how much?
So usually the significant symptom, we say if somebody is suffering twice in a week, we call it as these are very significant symptoms. Infrequent, they might be suffering once a week or once in a fortnight.
Okay.
But these two are very classical symptoms. These symptoms usually they feel more on lying down, because when they lie down, the stomach goes up and food pipe goes down, and if the wall is not competent, the reflux will happen. Second, they will have more symptoms in the night time. Similar mechanism, they are lying down. Somebody who with the heavy meal, when they go to the party or some marriage function, and then they develop these symptoms. So when they come with the classical history, they are getting these symptoms during these special occasions,
and more than twice a week,
with heartburn and regurgitation, it's more goes in the favor of reflux disease. So clinically, usually with this history, we diagnose it as a reflux disease. We start some medicines. If they respond to the medicine, that also confirms the diagnosis of GERD. Few patients where we are not able to fix it, whether it's GERD or some other causes, there they need investigations. Something like upper GI endoscopy, where we put the endoscope through the mouth and we go into the food pipe and stomach. We check the wall, whether it is competent or not. We see some changes in the food pipe. Because of this reflux, there happens some erosions, some ulcerations, some changes in the mucosa of the esophagus or food pipe, which gives us the idea whether there is a reflux or not. And then there are other some investigations are there. They are usually required in special population. Something called as the gold standard to diagnose GERD is a 24-hour pH monitoring. So even in some patients, not some, I can say, quote the figures also. So almost 30 to 40% of the patients, endoscopy will be normal. Still patient is having gastroesophageal reflux disease. This is called as non-erosive reflux esophagitis. This is a special entity. When we are suspecting strongly GERD and his endoscopy is normal, his symptom profile is not completely fitting into GERD, then we subject them for this test, which is called as 24-hour pH monitoring, where we monitor the pH in the esophagus. pH is, we understand, acidic pH and alkaline pH. We monitor 24-hour pH in the food pipe. If it is dropping below some levels, we calculate some scores, and which 100% confirms the diagnosis of GERD. So these are the tests we do to diagnose GERD, and these all are available in our setup at present.
Okay, doctor, but would GERD go away by itself?
GERD, if I mean, wish it would go away by itself with the lifestyle modification and other things, and coupled with weight loss, following diet, and getting rid of smoking and alcohol habits. But many patients are not relieved of the symptoms what they have, despite them stopping all these bad habits, which are essentially overdoing the smoking and the alcohol part, or shedding some weight also. Even then, they don't get rid of these symptoms. So when they don't, there comes the medical kind of treatment, that we need to initiate medicines for them because they won't respond. And if you let them be with those symptoms, it is really detrimental for them in the future. They have a lot of complications which may further make them suffer. So that's the reason we have to put them on first line medicines and see how they do.
Okay. Any other potential side effects of long-term GERD, suppose it is not treated? Any potential side effects, say, on digestive health?
Yes. So GERD is having a lot of complications. That's why we say don't neglect it. It's a serious disorder. So although it's very common, as we said, 20 to 25% of the people are suffering, although we need to pay attention to that, because the acid which is coming up from the stomach to the food pipe, constantly it damages your food pipe. So it can lead to something called as stricture. Stricture is narrowing of the food pipe. So it will stop the food going down into the stomach. So it can lead to the symptoms called as dysphagia or difficulty in swallowing. Some patients develop something called as Barrett's esophagus, where the food pipe mucosa changed from one particular type of mucosa to another, we say squamous to columnar, which is the pre-malignant condition. So this Barrett's esophagus in future has a potential to develop into the carcinoma of the esophagus. Third, sometimes patient develops blood vomiting because they get a lot of ulcers in the food pipe with this recurrent reflux, and which leads to the blood vomiting. So they have major potential long-term complications with this GERD.
And with these symptoms, if the patient sometimes, if they cough and there is a lot of retching that they have, the dangerous complication can be even tears in the esophagus also.
Yes.
The food pipe can tear up, and the consequences are sometimes lethal.
Okay. Doctor, what about triggers? Are there any triggers that individuals with GERD should avoid? Say you're already undergoing treatment, but are there any triggers?
Yes.
To avoid flare-ups,
Yes,
for example.
precautions-wise, one thing we have already discussed about is they should avoid the risk factors such as smoking and alcohol and untimely food, consuming excess amount of water immediately after their meal, whatever the meal it is, morning, afternoon or evening. So if these things can be avoided to a great extent, they can prevent their symptoms. Now, coming to the other part, that is, the treatment part. If you put them on medicines and if they are responding, that's a very good thing. To prevent the flare-up is the best way to deal with is medicines, because they are done with the initial factors, preventing the exposure to risk factors. Next thing is put them on medicines. That way, they will be having a good quality of life. If they have a good quality of life and if they practice good exercise and weight loss, it will be easier for them to go ahead with their thing.
Doctor, would you like to discuss the treatment options that are available?
Yes, so the first treatment option we discussed is a lifestyle modification. It's the most important, where we suggest to have every 4 hours small meals rather than having heavy meal at a time. Try to avoid late evening snacks or late night meals, because after that patient goes to the sleep and it starts coming up. Third, there should be a gap between your dinner time and your sleeping time. At least we say 1.5 hours to 2 hours should be there. Those who are suffering with GERD or gastroesophageal reflux disease, we suggest when they lie down, their head end of the bed should be elevated. So that prevents the reflux. These are the simple measures they can follow. And as Jagannath rightly said, avoid smoking, alcohol, coffee, chocolates, and as I mentioned, carbonated beverages. They definitely help to reduce the symptoms. Apart from this lifestyle modification, second thing is a medical management, where we start some medicines, something called as proton pump inhibitors. These are the gold standards for the treatment of GERD. They are very effective. So in 6 to 12 weeks treatment, almost 98 to 100% healing happens. Healing means whatever damage has happened in the mucosa of the food pipe completely gets healed.
Is it a long-term treatment?
Yes. So the most important, good point you raised. So GRD always considered as an acute problem, but it's not acute. It's a chronic condition where there will be relapsing and remitting course. So once any attack happens, like we say heart attack, similar thing, whenever GRD symptoms are precipitated, they need treatment that point of time. Some patients require maintenance treatment depending on how severe is their GRD, and some patients require SOS treatment. So whenever they are having a symptom, they should take some medicines.
Okay.
But this should be considered as a long-term problem. It's a chronic disease. It's not an acute
It
disease.
doesn't go away.
So there are few conditions, as we earlier mentioned, called as hiatus hernia. If we treat the hiatus hernia we stage during the endoscopy 1, 2, 3, 4. In stage 4 hiatus hernia, somebody is having refractory GRD symptoms, we suggest they need a surgical treatment. If they go under the surgery for that hiatus, their GRD symptoms gets completely cured, or they get treated in one shot for rest of their life.
Okay.
So there are few conditions where we can correct them and they will be symptom free for the rest of the life. But these chunk of the patients are hardly 20-30% of the patient. Rest 70 to 80% of the patient we need to manage with the lifestyle modifications and medicines whenever they are required. This is the basic management of GRD. Anything you want to add?
One more thing about the risk factors you were to ask. I wanted to mention that many people have this thing about hot liquids. Should we drink hot water? Should we drink cold water? So generally the temperature usually plays a role in the GERD symptoms wise.
Okay.
Anything hot, any hot beverage or any aerated beverage, they can actually accentuate the symptoms of a reflux disease. So, and carbonated liquids, why do we say don't take carbonated liquids, too much of them? Because the principle here is whenever there is an increase in volume of the stomach, as I think I told you already, any volume increase inside the stomach, that can increase the chances of reflux.
Okay.
So that's the reason we always say avoid aerated drinks. And temperature also is very important because...
So not too hot, not too cold?
Yes. A room temperature kind of thing is always better to go with somebody who has an established kind of GERD in those.
Doctor, you mentioned something about every 4-hour eating.
Yes.
So what you're saying is intermittent fasting is out?
So in GRD patient, yes, I will say no. So every 4 hours, small meal should be there. If you ask me specifically, even that also avoid very fatty meals, because these very fatty meals increases the reflux. Again, because they take more time to get from stomach to the small intestine. The longer they stay in the stomach, their chances they will come up.
Okay.
They will come to the reflux. There is something called as diabetic gastroparesis, or gastroparesis happens with a
Yes.
lot of conditions.
Leading to something called delayed gastric emptying.
Yes, so this gastroparesis means stomach is not emptying whatever contents there into the small intestine easily. So it takes more time, longer time. That's why this condition develops. Again, it leads to the GRD because lot of food is remaining in the stomach for longer duration. It tries to come up or pop up into the food pipe.
So now you said avoid fatty foods. What foods are good? What foods are okay?
So there is nothing like good food we can say about what you can avoid. So which we already stressed upon, like coffee, chocolate,
Okay.
carbonated beverages, more fatty food, and definitely the spicy food. Wherever oil and chilies are more, definitely these are irritants, leads
So
to the
basically
more.
your steamed, your
Yes, and the way he mentioned extreme
Healthy.
temperature.
Yes. See,
Okay.
recent trends are all about quantity of the food. Balanced diet, which is very well balanced with respect to protein, fat, and carbohydrate. Quantity is small, and it doesn't matter if it is too much of masala or a lot of oil. I mean, that doesn't matter, but the volume is something that is very important.
the
And
quantity of
temperature.
the food.
Yes, the quantity of the food and temperature of the liquid that you drink. It plays a major role. The other thing, the oily food and masala, it does add to a little extent increase in symptoms, but not to a great extent. Quantity-wise, if you space it well, it's very beneficial.
Okay, Dr. Badave, could you discuss any recent advancements or emerging treatments in the field?
So as we discussed the main management, we say lifestyle modification. Second is we say medical management. So some medicines are available which are very effective. Those patients who are something called as refractory GRD, they are not responding to the medicines, or somebody who is requiring medicine every day, for the rest of the life. So somebody who is 30-year-old male, he can't take the rest of his 70 years one tablet every day. He's having own side effects when they take it for such a long duration. In that case, we need to think about beyond this medical management. So there comes one surgical management. I think Dr. Jagannath will speak on that. I'll speak about something called as endoscopic treatments.
Okay.
So there are newer endoscopic treatments available now, which are, I can say, still in the pipeline. Few of the centers are practicing it and they have shown good efficacy rates. So one is a strata. Strata is what? So they put a radio frequency ablator into the food pipe. So it's radio frequency waves. With that, they damage the esophageal mucosa near the sphincter or near that wall, so that there happens injury to that mucosa. When this mucosa gets healed, it forms a fibrosis and it leads to the tightening of the sphincter. So the basic mechanism is you create the injury
Scarring.
artificially, and once that scar is formed, that area becomes more tightened because of fibrosis. Second, there is called as TIF, which is transoral incision-less fundoplication. So what surgically it can be done, it can be done now endoscopically as well, where the endo sutures are available. Through the endo sutures, they tighten the wall by taking the
Okay.
sutures through the endoscope without
This is
any.
all non-invasive.
This is all non-invasive. This is through the endoscope, so without any scar on the body. Third is there is called as ARMS, which is called as anti-reflux mucosectomy, where at the fundus is one part of the stomach where the food pipe and stomach are connected. Exactly at that junction, they again create an injury by another technique called as Aragon plasma coagulation, or
Okay.
sometimes they cut that mucosa with the endo knife. And again, same principle, when that whatever wound gets healed by the fibrosis, that area gets tightened or that sphincter gets tightened. So these are the newer treatments available, but still I will say they are in the pipelines. There are some studies which are showing very good efficacy, but they are still available in very few centers in India.
Okay. So they're not, it's not being widespread, not used.
Not easily available, not being widespread, and I feel they require more studies in more number of patients to say confidently, yes, this is should be the treatment of choice.
I mean, these procedures can be, can be offered to patients who are looking at a short-term relief. So long-term results are still awaited, and efficacy-wise, yeah, that's the only question there. Efficacy, how long? How long can they wait before the surgical plan becomes imminent? Then you have to undergo surgery. There's nothing beyond this without surgery.
Okay.
So till that point. Now, when we come to the surgical management, these are endoscopic managements, what Dr. Rohan discussed. Now, there are a lot of surgical techniques. Main idea is the same thing. There are different techniques which are used to control the symptoms, or these entire surgical procedures are clubbed under anti-reflux surgeries. So nowadays the surgeries are mostly laparoscopic. So there's an entity called laparoscopic anti-reflux surgery. So there are multiple procedures which are done. Now the surgery basically concentrates on the junction of the food pipe with the stomach and the diaphragm. Now any patient who is endoscopically diagnosed to have hiatus hernia, because hiatus hernia is something that cannot be treated by medicines.
Okay.
Now hernia is something where there is a gap or an opening through which something is coming out of the place where it is supposed to be. So if there is a documented hernia which can be diagnosed by endoscopy, primarily endoscopy, and then CT scan also can be done to detect how wide or how big it is, whether it is complicated or uncomplicated. When I mean complicated is, we have seen patients wherein the entire stomach can go and sit in the chest of the patient, very next to the heart of the patient, or sometimes towards the lungs also. So these are complicated patients wherein the opening in the diaphragm is so wide that intestines can also go inside the chest. So now initial part of the treatment concentrates on the diaphragm opening, the food pipe and the stomach junction. We need to increase the pressure at the gastroesophageal junction, that is at the point where the food pipe converts into stomach. Now the latest technology what we have, latest I mean it is there for almost more than 5 years now. It's the device is called Lynx. It is manufactured by some company. So these are about augmenting the sphincter. So these are magnetic sphincter augmenting devices. So these devices can be placed inside a patient by a laparoscopic technique. So when we say laparoscopy, it is a surgical method wherein the patient will be under general anesthesia, and then we make tiny holes on the patient's tummy, and we use this magnetic sphincter augmentation device and we place it around the patient's lower part of the food pipe, where it joins and becomes the stomach. So in that way, that magnetic sphincter device, which is metallic device, it holds the lower part of the food pipe in place, and whenever there is a food passing down, it stretches open and allows the food to go inside the stomach. Otherwise, it is closed.
Okay.
So when the food is not passing, the acid cannot go back
Come
into the
back
food
up.
pipe. That is the principle behind magnetic sphincter augmentation devices. There are some limitations, there are some complications with every procedure, so even this one has. Now, after this, we have the surgical procedures, which are actually going to concentrate on the stomach and the food pipe and the diaphragm anatomy. Now, as I said, hiatus hernia patients will have a very wide opening in the diaphragm. So when we do a surgical planning, it is a laparoscopic surgery, wherein again the same thing, patient will be under general anesthesia. And we use tiny holes in the patient's tummy. We go inside the abdomen, and there we look at the problem. What are the problems patient actually has? We already know that endoscopically patient has hiatus hernia, CT is showing these other things. But when we look at the surgical anatomy, it may be the same or it may be little different. So our idea is to basically decrease the size of the opening that the food pipe has. After we start the surgery, we bring the entire complex, that is stomach and the food pipe, back into the stomach. And then we make the opening a little narrower. Narrower, I mean make it optimal for the food pipe to just enter. Okay. Not too wide so that it can pull the stomach into the chest. So when we make the opening a little narrow, just enough for the food pipe to enter, that itself decreases the chances of reflux. Now, in addition to making the opening smaller by placing stitches, we do wrap up some portion of the stomach around the food pipe so that the lower part of the food pipe is held by stomach wrapping around it. That is the reason this procedure is called fundoplication. The part of the stomach we wrap around is called the fundus. So when we do a wrap up of the stomach around the food pipe, that also increases the bulk of the lower end of the food pipe, and plus because of the stomach contractions, it can augment the sphincter. So as I said, the idea of surgery is to augment the sphincter, either by metallic devices or by doing a fundoplication. Now fundoplication, there are different wraps. We wrap it completely sometimes, we wrap it only partially. Either in the front of the food pipe or only in the back of the food pipe, or around 3/4 of the food pipe, depending on how strong the food pipe is.
Okay.
So to assess how strong the food pipe is, we do one more study before our surgical planning, that is esophageal manometry. I think Dr. Rohan should just mention about esophageal
So if you can
manometry.
tell us in short,
So
doctor.
esophageal manometry, main takeaway point is that esophageal manometry should be done in all the patients before going ahead for the surgery. So basically when we do the endoscopy, we see the mechanically, how is the mucosa, any mechanical obstruction, whether hiatus hernia is there or not. In esophageal manometry, we come to know whether our food pipe is working normally or not. So our food pipe should work normally. That is called as peristalsis. So whatever food we eat, our food pipe is not like water pipe where food immediately goes down. So it goes by 1 centimeter by 1 centimeter. This small process is called as peristalsis. So by manometry, we come to know whether our food pipe is working normally or not. If it is working normally, then they can go ahead with the normal surgery with full fundoplication.
So there are some named surgeries, as I said, anti-reflux surgery. There are different names which we have. For example, I can say Nissens is what they named. That's a gold standard surgery which is done in most of the patients who have hiatus hernia with reflux. There's another surgery called Toupet, DOR. There are so many named surgeries, and these all surgeries are named because of the degree of wrap around the lower part of the food pipe. And as such, every surgery has its own limitations, complications and other things. So when we talk about surgery, the results are wonderful compared to the non-surgical management wherein the patient qualifies for a surgery, such as patient has hiatus hernia, patient has GERD, patient has tried all possible non-surgical management, and the patient does not want to continue with medical management, or he doesn't want to go for the non-surgical management. He wants to have surgery. So we explain them about the limitations and the possible complications. In such surgeries, the only thing we are looking at is difficulty in swallowing. Sometimes patients do have difficulty in swallowing after doing proper assessment and then planning the surgery. So when they have that, we ask them to have another round of endoscopic widening of the surgical procedure that we do. So one is difficulty in swallowing. Another thing is people have bloating also. Even bloating is a minor complication which will probably go away in a couple of weeks after surgery. But overall, the relief from symptoms of GERD following laparoscopic surgery is very good, And people who undergo these things, they feel good about themselves, and this result is maintained for a long duration.
I just want to add one point. Not all the hiatus hernia requires surgery.
Yes.
So
Yes.
only the who are having grade 3 or grade 4, which we grade by endoscopically, only these subset of hiatus hernia patients require surgery.
There
Rest
are some,
we all discussed.
yes, there are some contradicting things also. A person may come, he may say that I don't have any symptoms, but we do suspect something and we do an endoscopy, and Dr. Rohan says no, he's got a very wide hiatus hernia.
Correct.
But the person does not have any symptoms. So we don't upfront offer the surgical options to him. And there are some patients who have initial grades of hiatus hernia, but their symptoms are not at all controlled.
Okay.
So even these set of patients are also there who need treatment. So it is not a diagnostic thing. It is comprised of all of things: the symptoms, the diagnostic things, what will benefit. So it's a combination of all these things which will help the patient improve.
Doctor, I think that's all the time we have for today. Thank you so much for joining us, for sharing your valuable insights on an overlooked condition, a common yet very overlooked condition. Dr. Jagannath Kulkarni and Dr. Rohan Badave are both available at Manipal Hospital Monday to Friday, 9 to 5 p.m. if you need to see them. Let's draw this insightful conversation to a close. Let's continue to prioritize our health and well-being, armed with the knowledge that we gained here today. That's all we have for today's episode of Health Mantra. Thank you so much for joining us. This is Heather saying bye for now. Until the next time, keep watching Prudent Media.